Thank you. Today you've heard a wonderful background on some of the histology and pathogenesis of the different types of cutaneous lymphoma, and I'm fortunate today to give you an update on some of the treatments of cutaneous lymphoproliferative diseases. Now I'll start with your most recent talk on primary cutaneous B-cell lymphoma. And I know that one of the original talks I've heard about it was the good, the bad, and the ugly. And fortunately, most of the patients that we hear or that we see are the good type, the indolent types, the primary cutaneous marginal zone lymphomas, and the follicular center lymphomas that you heard about from Dr. Guittard. And then I'll also just touch upon the more aggressive primary cutaneous large B-cell lymphoma leg type, and there's also a non-leg variant, which is a very bad player. Now, we're fortunate that for the treatment of the two indolent types of B-cell lymphomas, we have a number of good modalities, although recurrences are very common. But fortunately, we can reassure the patients that they should have, in general, a normal lifespan. And they don't believe us in the beginning, but after 5 years, they do. If they have single lesions or within one anatomic site, we recommend radiation or surgery, and there are some new guidelines out, but usually it's about 30 gray. If you have aggressive type, the large B-cell lymphoma, they often get combination therapy from the get-go, radiation, often with chemotherapy and rituximab from the very beginning, and even then they don't do as well, as I'll show you. Now, these are some graphs from the work by Senf et al. Showing the relapse-free survival for primary cutaneous follicular center lymphoma and marginal zone. And you can see that there are fewer relapses with the treatment for PCBCL with radiation than for marginal zone. But they do recur. There's a lot of recurrences. And here you have the large B-cell lymphoma type. But the bottom line here is that the patients with the indolent cutaneous lymphomas do well and have essentially a normal lifespan, where those with the diffuse large B-cell lymphoma leg type don't, no matter what you do for them. And their survival is, say, 55% at 5 years. Now, I don't guess that this is Oriel's tumor yet, even though he's now spending a year with us, but this was a patient who had the follicular type of lymphoma. And you see the large nodules here, and here he is after radiation therapy. These are some of the biopsy scars. And he's still without disease at 5 years. So he's more than 5 years, so he's doing well. But for the majority of our patients, we're faced with the fact that another spot pops up. And then they get upset. So from the very beginning, I tell them I practically expect another spot to pop up. And then I say, well, there's all different things we can do, that it's almost a cosmetic approach to lymphoma. And when I put it in that context, they feel better. So there are very few studies. They're all retrospective or anecdotal, but we often start with topical class 1 steroids like clobetasol, intralesional steroids. I become a fan of cryotherapy for some people. And you do the simplest things first that will keep the patient happy. Now I'll move to cutaneous T-cell lymphomas. And you've already heard a preview of coming attractions from Dr. Dubik with a lot of her very important work on understanding the pathogenesis of the disease. Now this is an updated slide. She showed you a simplified slide of the recommendations by the NCCN guidelines. And whenever a slide is this busy, you know that you really don't know what to do first. So you very much have to individualize this to the patient and what you have available. Now, 20 years ago, we would have had 1/10 of these options. So this has been a really good time, especially the last 15 years, for new therapies with this disease, which I've been happy to see. Skin-directed therapies I'll talk about. As she mentioned, that's for the early stage 1B and 1A and 1B disease. You also can use it for palliation. And then the systemic therapies are generally reserved for more advanced disease or recalcitrant disease, and that would be 3 and 4, and also some 2Bs with the tumors. One thing for the early stage patients with 1A and 1B, unfortunately that's most of our patients, you can honestly tell them that even though we call this lymphoma, we don't want to be terribly aggressive, and that there's a study, even though it was published a long time ago, which shows that if patients are treated aggressively, and obviously have all the side effects that go along with that, they don't do any better. In fact, they probably do worse, and I think Dr. Duvik alluded to that in her talk, that immunosuppressive therapy is not something you want to do for no good reason in these patients. So we often begin with skin-directed therapy and hopefully do it for as long as we can in patients with early disease, 1A, 1B, and 2A, where they really don't have lymph node involvement. We start with the simplest, usually the topical corticosteroids. UVB, narrowband UVB has now largely replaced PUVA because of concerns about later skin cancers, and it's probably just as effective, so that's what we do. And these are my two favorite things for early stage patients. Also, it depends on the color of their skin. And I'll talk about some of the others. So topical corticosteroids. It's hard for them to believe that something that works for poison ivy is something that you want to put on a lymphoma. But I explained to them that it really does get rid of some of the T cells that are misbehaving, that are the abnormal T cells. And then they say, well, if you told me aggressive therapy doesn't make any difference, why do I have to treat this disease? The first thing I say is it makes your doctor feel better. But then the second thing is that theoretically your body's own immune system is trying to keep it in check, and if we have fewer misbehaving T cells, you'll be able to do a better job of that. And then they usually accept it, and I get pretty good compliance. I love topical clobetasol. You're not supposed to use more than a 50-gram tube a week. And I take pictures. We have wonderful photography at Memorial. I tell the patients about the side effects, and I bring them back in 2 months to see how they're doing. And then I will often follow them closely in the first year. And yes, you can see stria. Here's a patient with minimal disease. She developed stria after 7 months, but her MF never came back. It's also very useful to use topical steroids like triamcinolone ointment as an adjuvant in patients with erythroderma and Sézary syndrome. Now, Bexarotene gel has been around for about 15 years. It is a topical retinoid, or actually rexinoid, an RXR inhibitor, and it gives you apoptosis, and it modulates cellular differentiation. You can tell the patient that about 2/3 of them will respond after about 6 months, but the problems are it's category X, although I know they've changed the categories in pregnancy because it's lipid soluble and is stored in the fat, and that bothers me in women of childbearing age. It's very irritating, and I'm not sure what company owns it right now, but it's always been really expensive. The problem is you have to ease patients into it with every other day treatment and stop them 2 weeks before you evaluate them because you'll have persistent redness from the retinoid effect. And this is a patient who had that, and the erythema extends way beyond where she was treating it. Nitrogen mustard, or topical mechlorethamine, has been around since the Second World War, and we'd always use it in an ointment versus a liquid suspension because the risk of contact dermatitis was much lower, and which really has been the limiting factor in its prolonged use. But recently, other investigators did do a study with a gel and got it approved by the FDA, Dr. Lesson and Dr. Kim and a number of the other people here, and it does have a good efficacy, probably better than the ointment, a 59% response rate. It can be irritating, and there's about a 30% risk of contact dermatitis. Also, it's not inexpensive. An old-fashioned one is topical Carmustine, or BCNU, which was used often on the West Coast by Dr. Zackheim. The problem was systemic absorption and irritant reactions. A recent study using an inhibitor of the alkyltransferase activity that's found in the CTCL cells was done, and they were actually able to give patients just as effective dosing, but with less cutaneous toxicity. I'm not sure if what's going to go on with future work with that, but that's been an effort to kind of resurrect that option. And then when patients have gone through everything, say phototherapy, and they've gone through the different topicals, and you're thinking about possible systemic therapy, or you have really recalcitrant disease, say heavy plaques in stage 1B disease, you think about total skin electron beam therapy, and we've been doing that at Memorial for about 35 years, the 35 years that I've been there. And in the olden days, we gave heavy doses up to 36 gray, and patients did very well, but they suffered telangiectasias, they couldn't sweat, they had edema, which is more acute, and also some skin cancers would happen, but you could only give one dose of TSCB. Now there's a trend to try to do a smaller dose, even though we know that higher doses result in better long-term responses, so that if a patient needs retreatment, they will have that option. So that's a current direction, and we'll have to see how that plays out, perhaps also followed by therapy after that. And the two adjuvant therapies that are probably used most commonly are oral Bexarotene and narrowband UVB following TSCB to maintain the remissions. Now, there are a couple of other skin-directed therapies that I just thought I should mention because this is an update. There are some case reports of using topical imiquimod in mycosis fungoides, but it was very irritating. It's almost like killing the cells as innocent bystanders in my mind, but there's an interesting study by Dr. Rook and the group at Penn using topical rosiquimod, which actually showed that some of the patients had resolution of distant lesions. So there was almost a systemic effect, which is not illogical with some of these topical agents. You're almost inducing interferons. And so this may be a direction that we'll see in the future, and I think it's also in clinical trials now. And also there's some topical histone deacetylase inhibitors that are in clinical trials for mycosis fungoides as well. Now, systemic therapies for mycosis fungoides and Sézary syndrome. And this is a slide from my associate Steve Horwitz. As I mentioned, you want to do the least amount of harm as possible. So this is his order of how we might give the medications. And we often begin with Bexarotene because we've had some of the longest experience with that. I still have one patient who was on the original study that we did with Madeline that was published and got this approved by the FDA. So I have one person on it for 16 years so far. So that's probably our first drug. We have the most experience with that. I'll talk about the side effects. Good old methotrexate is still up there, especially if a patient has both mycosis fungoides and lymphomatoid papulosis, which occurs in 8% of MF patients. And then interferons are often used, especially in Europe, but they're often used with Bexarotene, for example, in Sézary syndrome, and sometimes with retinoids or light. And I'll talk about the others. Now, Dr. Dubik mentioned ONTAC. I won't go into that one today, but Bexarotene is a rexinoid that, as I mentioned with the topical, is very effective in cutaneous T-cell lymphoma. It gives you apoptosis in the T-cells that are malignant, but the side effects are primarily hyperlipidemia, hypertriglyceridemia, and central hypothyroidism. The response rate's at 300 milligrams per meter squared, about 45%, and if the patients can tolerate more than that, it can go up to 55%. As a single agent, I don't think we've gotten any better in proving its efficacy. We tried in a study with interferon alpha, and it was just more toxic. They didn't do any better than with Bexarotene alone. We recently published a study with liposomal doxorubicin, and again, it did not improve the reported response over liposomal doxorubicin alone. And I believe Dr. Dubik has also looked into that with pralatrexate. So we're still, and I just don't know any combination that is better than Bexarotene alone at this time. The histone deacetylase inhibitors, vorinostat is an oral drug. These inhibit the tumor growth in vivo in animal models and also induce apoptosis and or differentiation in the transformed cells. Vorinostat was approved in 2006 and can be used in all different stages of the disease. The response rates tend to be quite similar with these HDAC inhibitors. And the most serious side effects in the first two clinical studies were pulmonary embolism and also squamous cell carcinomas. Our patients often seem to suffer GI upsets as well, and anemia. Romidepsin is an intravenous HDAC inhibitor, and has a 34% overall response rate and has been given in heavily pretreated patients, and this is also used commonly for people with advanced disease. Now, I think you heard a little bit about mycosis fungoides' bad cousin, peripheral T-cell lymphoma. There's the type that's associated with HCLV1, and then there's the type that is PTCL NOS, as you heard. And there have been some strides made in the treatment of this disease. Pralatrexate was the first drug that was approved for this in 2009. It was actually developed by Francis Sirotnik, who was a pharmacologist and researcher at Memorial, and it's an antifolate that did have some responses in mycosis fungoides, and it also can have some efficacy in patients with cutaneous T-cell lymphomas and mycosis fungoides, as was just published in Blood. Belinostat is another HDAC inhibitor, and Dr. Dubik has done some work. This has been approved for peripheral T-cell lymphoma, showing its efficacy in some patients with peripheral T-cell lymphoma and cutaneous T-cell lymphoma. And romidepsin is also approved for PTCL. Now, you've heard it in a couple of talks about some monoclonal antibodies and their use in cutaneous T-cell lymphomas. Alemtuzumab, the anti-CD52, is approved in refractory chronic lymphocytic leukemia and multiple sclerosis recently. It's been used in erythrodermic mycosis fungoides. It knocks out everything as far as any cells, BET, that have this receptor, and patients often have problems with severe opportunistic infections like cytomegalovirus and herpes zoster. CMV is probably the biggest thing. Zenalimumab, you've heard about from Dr. Dubik, I think, or maybe not, but this is an anti-CD4 antibody that had shown some efficacy. I'm not sure where it is in trials now. And mogamulizumab, she also mentioned the anti-CCR4 antibody, which is approved in Japan, has shown some really interesting results in patients with cutaneous T-cell lymphoma, especially the patients with Sézary syndrome, who had a 47% response rate in her recent paper in Blood. And then the one that a lot of us are kind of excited about right now is an immunoconjugate that you heard about, brentuximab vedotin, an anti-CD30 antibody conjugated with a tubulin inhibitor. It's now already approved for systemic anaplastic large cell lymphoma and Hodgkin's disease, and currently has shown some progress in some of these lymphoproliferative disorders that is quite striking, as I'll show you. Now, a few other clinical trials. Lenalidomide, which has been used for multiple myeloma, was shown by the group with Dr. Gittard to have a 28% overall response rate in some patients with refractory CTCL. That was also recently published. And we have an ongoing trial of lenalidomide and romidepsin, which is being led by one of our fellows, Neha Mehta Shah, and this is really kind of very promising in some patients. So, stay tuned to see what that's going to show. There's a phase 3 multi-center trial of mogamulizumab versus vernistat, and also another phase 3, which actually is just closed. We've just finished, brentuximab versus methotrexate or bexarotene in CD30 positive CTCL and lymphomatoid papulosis. Now, you heard about CD30 positive lymphoproliferative disorders. CD30 is a member of the tumor necrosis factor receptor superfamily, and it's member 8. First found on the Reed-Sternberg cells of Hodgkin's lymphoma. They used to call it Key1, I think, in the olden days. I remember the olden days. And you can see it on normal cells, but really activated T cells and B cells and virally infected cells. And CD30 lymphoproliferative disorders really are a spectrum of disease from lymphomatoid papulosis, where the lesions are supposed to be less than 2 centimeters, and involute. But I think there's always rules to be broken because some big ones involute too. And anaplastic large cell, where the nodules persist. And in those patients who you worry more. And here are 2 patients of mine. This is a patient with lymphomatoid papulosis. This is a new lesion. You can see the atrophic scars that occur even with no treatment in lymphomatoid papulosis. And here you have a patient who had primary anaplastic large cell lymphoma and received radiation to the skin. Now, what about the treatment of CD30 lymphoproliferative disorders? And I always find it hard to explain these to a patient because you heard about how the classification of T-cell disorders is constantly changing. And I say in Europe they think it's a malignancy, but here we don't. But it can be associated with a malignancy. But they've already looked that up on the internet anyway, so they kind of know that. But it's hard for me to explain, so I just explain we'll follow them and try to get rid of the lesions and make sure nothing bad happens. So probably the most frequently used things are topical corticosteroids, again, clobetasol or betamethasone or halobetasol. PUVA has been reported a lot, especially in the European literature. And then if lesions just don't go away, many people would first go to low-dose methotrexate given weekly until the patient's disease is controlled, and then to taper it. And of course, you have to tell them not to drink alcohol and warn them about the side effects. Oral bexarotene and interferon alpha have also been used with some success. For anaplastic large cell lymphoma skin only, it can be either surgical excision or radiation therapy in fairly large doses, 30 to 46 gray. And this would be, with a large field. And chemotherapy is often indicated if the lesions are multifocal. And these are from some of the guidelines that were published by a number of the lymphoma groups in 2011. Now, you've heard about brentuximab, and as I said, we're quite excited. And this is Dr. Duvik's work, and she showed it more in detail. And as she showed you, 73% of the patients had a response rate, and 35% had complete remissions. This is astounding. And she did not find that CD30 expression was that relevant to response. I hope I'm saying this correctly. But all those with LYP and anaplastic large cell lymphoma did respond, and they responded pretty quickly, 3 weeks. The problem is peripheral neuropathy. That can be dose limiting in some patients. And this is a similar study between Memorial and Stanford with Dr. Kim and Dr. Horwitz in our patients, showing very similar results. This was in patients with mycosis fungoides and Sézary with variable CD30 expression. This was 30 patients. The overall response rate was very similar, 70%, but they did find a relationship that if the patients had less than 5% CD30 expression, they had a much less global response versus those with greater than 5%. Again, peripheral neuropathy was the most common side effect. So now Dr. Horwitz is thinking of trying it in some of our MF patients, but he really wants them to have a threshold of 5% CD30 positivity in their biopsies. I just did one yesterday for that. So in summary, I've given you a pretty fast talk. Cutaneous lymphoproliferative disorders present a complex group of neoplasms with variable presentation and prognosis, very different biologic behaviors. When you have to decide what to do for a patient, it's multifactorial. You have to know what you're dealing with. You have to know the pathology, as you heard. You have to know what you have at hand and what the patient has access to, which is an increasingly important issue in this day and age, and what the patient's choice is. A lot of my old ladies who live way out in the suburbs or the country are not going to go for narrowband UVB 3 times a week. They just can't. So we have to really compromise. There are a lot of new and effective treatments for CTCL and CD30 positive diseases, and as Dr. Duvik mentioned, there are some exciting new directions that we'll be seeing, like the JAK inhibitors, the ALK inhibitors, and as we learn more about the mechanisms and pathways, there'll be more new treatments in the future. Thank you.